everyone, and welcome to today's webinar, Turning Information into Intelligence, How St. Joseph's Command Center Hub Maintained Continuous Capacity During the COVID-19 Crisis. This is Mackenzie Bean, Managing Editor with Becker's Healthcare, and on behalf of Becker's, thank you all so much for joining us. Before we begin, I just want to walk through a few quick housekeeping instructions. We'll begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link that you used to log into today's webinar to access that recording. If at any time you don't see the slides moving or you have trouble with the audio, please try refreshing your browser, as that might help. You can also submit any technical questions into the Q&A box, as we're also here to help. With that, I'm so pleased to welcome today's speakers. Joe Bick is the Manager of Care Compass and Hospital Operations at St. Joseph's Hospital Health Center in Syracuse, New York. Joe has over 30 years of expertise in nursing, hospital operations, patient flow, and emergency management and disaster preparedness. He began his career as a cardiothoracic staff nurse and quickly moved into leadership roles both in the hospital setting and as an officer in the U.S. Army Reserve. Beginning in 2014, Joe's role expanded to include responsibility for patient flow at St. Joseph's Hospital Health Center. In 2016, as Director of Acute Care Coordination, he led the effort to institute a new kind of operational command center hub that would transform the way the hospital managed care coordination and patient flow. Also joining us today is Brooke Breinig, who is the Senior Project Manager at Care Logistics. Brooke is an established deployment manager with over 13 years of project management experience, including EHR implementations and process improvement initiatives. She began her career as a project manager with Epic, focusing on patient access processes and technology installations before transitioning to managing the implementations of hospital operating systems with Care Logistics. Having the integrated knowledge of an industry-leading EHR, Brooke knows how to successfully implement new processes and software in hospitals while integrating with established systems. So Brooke and Joe, thank you both so much for being here today. I'm really looking forward to this presentation. So with that, I'll turn the floor over to Joe to get things started.
Thank you. Hi, good afternoon. For those of you who don't know me, my name is Joe Bick. I'm from St. Joseph's Health. Some things we wanted to cover today in our presentation. We want to talk about what continuous capacity means, specifically during the pandemic. Go over some tipping points where we know when we will have a problem. Talk about the importance of getting things in order before the crisis hits. And finally, talk about some of our key command center metrics as we go through. Okay. A little about St. Joseph's Health. You can see our numbers are here. We've been in the Syracuse community greater than 150 years. We're a magnet hospital and have all this cool stuff that's listed on the slides. All right, to get right in it, continuous capacity. It means on a day-to-day basis that we have physical capacity to provide care for whoever wants it in our community, whoever presents themselves. It means admitting patients in a timely manner from our emergency department. It is our ability to continue to do elective surgeries and in the event of the pandemic, medically necessary surgeries. And it also means being flexible with our staff to create capacity when we need it. One of the key things during December and January of this year, hospital capacity was the determining factor in keeping our regional economy open. To talk about Central New York and the Syracuse region, Syracuse is essentially the central city in New York State. The Central New York region covers 5 counties, 4 rural counties. Each of them have a hospital. and one urban county, which is Onondaga County, which Syracuse is in. There are 8 health systems. 4 of them are in the Syracuse area. The remainder are in the rural counties surrounding us. And as we went through the winter of this year, after Thanksgiving, we had a massive uptick in COVID patients and COVID admissions. And that really gave us an opportunity to test literally to the limits all the things that we had put in place to manage patient flow and patient care in our organization. So the hospital capacity crisis, this is from a December 9th article on Syracuse.com, which is our local media outlet. Obviously, Governor Andrew Cuomo and the governor's office very carefully keep tabs on all aspects of the COVID outbreak, hospital capacity being one of them. We were required to report to the New York State Department of Health daily our capacity and our acute care beds, and we'll talk more about what New York State thinks acute care beds are. Back in December, they had a green, orange, red zone, and based on what zone you were in, determined whether non-essential businesses would be open or closed. So that is what we are, or were up against in the middle of December of 2020. So we talk about the regional capacity. This slide is actually from the New York State's COVID website, and they talk about what our hospital capacity is. And I know it's a little blurred here. So my friends from Care Logistics were able to blow this up for me. One thing that I wanted to say that I didn't say at the beginning is that in full disclosure, I have no financial relationship with Care Logistics in any way, shape, or form. I just think they're awesome. So with that being said, this is what hospital capacity looked like in December and January in the Central New York region. We were down as low as 12% capacity. The state wanted to be notified immediately. They actually set up a hotline if your hospital was going to be, your occupancy was going to be over 85%. But this is what they looked at on a daily basis based on the information that we reported to them. Impact on St. Joe's. Obviously, anyone who works in a healthcare facility understands and appreciates how devastating, for lack of a better word, the COVID pandemic has been on healthcare here in the United States. In the spring, in April, when it was rampant in the New York City area, the state had actually ordered all hospitals to suspend elective surgeries. Almost for a period of almost, I want to say 7 weeks. It could be wrong, but it was at least that. As you know, well, I don't know that you know, but in New York, a not-for-profit state, elective surgery is how we pay for mental health. It is how we pay for medical care. It is how we finance the whole operation. So that was a challenge to us significantly. Acute care discharges went down. Acute length of stay went up. ED visits went down. You know, I went to a meeting in February of 2020 with the community, and there was serious concern that all the emergency rooms would be overwhelmed with people who thought they had the disease and didn't. And as it turned out, we went through the pandemic, instead of doubling our ED volume, and cut it in half. And we continue to recover from that. As we look at the peak, 14.1% of our patients were COVID. I can tell you that around the 23rd of January, 1 in 3 patients in our hospital had COVID and was on one of our COVID units that we were able to expand as needed as we continue to get the patients in. All right. So the state didn't want to shut down the regional economy, and they had asked the Healthcare Association of New York, Haney's, to meet with the hospital CEOs every day to talk about mitigating the hospital capacity problem. We realized early on in that process that we needed standardized data and reporting so that all the hospitals were essentially speaking the same language when it came to beds. Hospital census data is a funny thing in so much as for some entities, you only count inpatients. For some entities, you count inpatient and observation patients, or you report all the beds that you're licensed, not necessarily all the beds that you use on a day-to-day basis. We, in consultation with the New York State Department of Health, narrowed our focus to acute care beds. And for the purposes of COVID, acute care beds are med-surg beds and ICU beds. And the number of patients in those beds without regard for their status, inpatient, outpatient, observation. And as you'll see as we go through the statistics, we've included inpatient and observation patients in our statistics. We looked at all the hospitals in the region during these meetings to see who had reported having capacity. And then we worked to load balance. I'm going to start coughing, but I don't have COVID. Then we worked to load balance between the hospitals so that no one hospital could not provide their critical functions in the community. So these are things that we looked at on a daily basis. Here at St. Joe's, most of the time we looked at all of these things every day anyway. Our ED visits, the number of COVID visits our ED had. We certainly looked very specifically at our COVID census, the discharges, the admits, patients in the ICU, our numbers of vents in use. When we started in April and May, ventilators, as the governor would like to say, were a critical thing, but we never reached a point where we didn't have sufficient capacity for ventilators anywhere here in New York. And as we talk with the other hospitals, sorry, no COVID, swear. As we talk to the other hospitals, we had to get everybody on the same footing, talk about what our total census was, talk about our ICU census, our NICU census, even though that didn't count in our acute care beds. When you report to HHS, they counted NICU as a pediatric ICU, so they wanted that counted. Our med-surg census and our acute care census was med-surg and ICU. And again, it was people in beds without regard for your status as a patient. We looked at the previous day's discharges. We looked at anticipated discharges because that allowed us to plan ahead. We had put in place here at St. Joseph's mitigation factors. We had, I won't call it a break, but a significant decrease between May and October of patients who had COVID. So our mitigation strategy in order to maintain patient flow in our hospital on a regular day was our same mitigation strategy to maintain patient flow at the height of the pandemic. We focus on every day in every place, length of stay and discharges rather than admissions. We look at data drivers every day, 7 days a week. Leadership sees where we stand. What that does is give us real-time situational awareness. When there is when things aren't flowing as smoothly as they should be, we almost always know the answer right away just looking at the indicators. We have, with the help of Care Logistics, put in place a care coordination model that has continuously served us well since 2015 into 2016 when we implemented it. And part of that is our ability to prioritize who needs their diagnostics done first based on when they should leave the hospital. So all of those things were critical mitigation strategies moving forward. What we wanted to do when we began to meet with other hospitals with the health of the detainees is to indicate what the tipping points were as we progressed through the crisis. The first day, I think the first day we met was the 22nd of December with the other hospitals. All the hospitals had gotten a call from the New York State Department of Health at 1 a.m. because one of the hospitals in the community was just at their max, and we're on the brink of not being able to provide their critical services to the community, trauma, burn care. They're our big trauma center. Life-saving cancer surgeries, they do surgeries that no one else does. As we look at St. Joe's, cardiology, invasive cardiology, open heart surgery, are critical things that we do in the third health system, neonatal ICU. While we have some capacity, their capacity is 10 times what ours is. So those are critical services that the community needs all the time, whether there's a pandemic or not. So we decided, that group decided, the CEOs decided that those were the things that had to be maintained, and when you couldn't, that was one of the tipping points that required further mitigation. Internally at St. Joe's, greater than 20 ED admitted holds with no possibility of them moving out of our emergency department. What we find is that we discharge patients about 12 hours a day and we admit them 24 hours a day. So sometimes we get behind. So 20 is our threshold for that. The state had required initially that hospitals be able to surge above their licensed capacity by 25%. Almost all the hospitals in the Syracuse area have the physical capacity to do that. Staffing is the challenge around that. That was required by the state, but as time went on, they realized it was more important to stay below, or try to stay below, 85% in total hospital capacity in the 5 counties. So as we look at the data, we're going to look at the data from the city of Syracuse, keeping in mind that the rural hospitals that we support had further capacity. The inability to take transfers from critical access hospitals. Well, Central New York region is 5 counties. We service a 15-county area that we routinely take transfers from. Not only us, the other large hospital system in Syracuse also takes those transfers as a level 1 trauma center. So our inability to do that really has a negative effect on patient care throughout the entire middle of New York State. And finally, the inability to provide ED services. When you can't effectively move people in and out of your emergency department, you have to go on diversion, or you have people stacked up in the hallway. And we wanted to avoid all of those. So that brings us to the tools that we use to try to keep a lid on this controlled chaos, if you will. Some of the challenges as we talk about how we set up our hub and converted that to our crisis command center. We do have in here, we have a medical record that's the best electronic medical record there is, but it's not patient logistics. We had engaged Care Logistics based on our inability to move patients out of our emergency room in a timely manner. I mean, that is the long and short of it. And we had done everything in the literature, spent almost 6 years on it, and still could not get the outcomes that we wanted around that. So we launched our Care Compass initiative. I was the project manager on the St. Joe's end. Brooke Brining was the project manager on the care logistics end, with some goals in mind. We wanted to reduce our length of stay. Turns out that's the key to patient flow. Who knew, right? We wanted to be able to maintain our quality and patient safety. And we absolutely have been able to do that as a lead Prog A hospital. Everyone wants to reduce cost all the time. And, we want to be a provider of choice. And we wanted to be able to create capacity when we needed capacity. And boy, were we ever during COVID. So this is where we started. And I think this is important background as we look at pre-COVID. A reduction in length of stay of almost a day fundamentally changed how we did business here at St. Joseph's. We suddenly, for the same volume, needed 57 less inpatient beds. Our observation length of stay came down. Our case mix index came up. And use of overtime really to staff almost cut in half. So we were very, very pleased with those results. And I can tell you that going into COVID in February of 2020, we had some of the best outcomes that we have ever had, with a length of stay under 4 days in February. And then, of course, COVID changed all that for a whole year. Now it's Brooke's turn to talk.
I'll give Joe a minute to have some water. So what you can see here, Joe talked a lot about this already in our Care Compass project that we named it, the initiative, to stand up what you see that's depicted on the right side of the screen, which is the Operational Command Center Hub. So when we set upon this journey, we all focused on that strategy deployment in human systems. We created a system aim so that everyone had the same true north from an executive level all the way down to the front line. St. Joe's chose a higher level of care every patient every time, because that really was their true north to provide that higher level of care to all of their patients. That center image is the command center hub. We also work to with the spokes, so you can kind of think of it as a hub and spoke model. And we work with all of the different areas in the hospital. So your admission sources, your ED, your PACU, all those places where your patients are being admitted from. Your nursing units, where your patients obviously are until they discharge once they're admitted. Your service areas, so think of your diagnostic areas like X-ray. All of those areas are somewhat managed from the Operational Command Center Hub. And the technology that we put in place supports those roles in the hub. You can think of the Command Center Hub and the care logistics technology and processes as a second layer, a focused layer to the EHR, your EMR. It really has that bi-directional communication with your EMR. It gives you real-time actionable data so that you have the right tools, like Joe has referenced, at the right time. And it's all about putting the right processes in place and then layering on that technology to support those processes that you put in place. With all of this, St. Joe's really was able to stand up a hospital incident command center during the COVID-19 crisis much more easily, I think, than other hospitals, because they already had that command center hub and that real-time data that's needed to be able to react to the crisis, the pandemic.
Sorry, I'm supposed to be doing the slide.
It's okay. We talked a little bit about this, but I referenced the technology and how we have that bi-directional communication with the EHR. Joe already mentioned patient logistics. That really is managing your admissions, your transfers, and your discharges, or what we think of almost as like air traffic control, to give you all the tools you need to progress your patients throughout the system. And then order logistics is that management of making sure that Joe said quite a few times that chaos of the day is managed from a diagnostic perspective for your inpatients. So a lot of times inpatient service management or inpatient procedure management leads to a lot of white space. And so it's all about having that visibility so that you can eliminate some of that white space for your patients who do need procedures in order to progress in their care.
Thank you, Brooke. If you work in a hospital, you know that the Hospital Incident Command System, or the HICS, is a requirement from CMS that everybody has in place. And really, for us at St. Joseph's, we have a command center that we run every single day. And then when extraordinary things happen, we activate our incident management team and in a larger room, and we can mirror all the inputs that our hub has in our command center, so that the incident commander, the hospital CEO can make decisions based on that information. It's hard to start from scratch, though, when bad things are happening. So if you have all of these things worked out beforehand, then it is a matter of taking the information that you have, and this is where the presentation title came from, taking the information that you have and turning it into intelligence, which is information that leaders can use to make decisions right now. We had all the things in place, so we didn't have to guess. We didn't have to wonder where we were. We knew exactly where we were all the time. And that really was critical to being, you like to use the term agile. Sorry, I got to get more water. Agile in our response. So as we go into the event a little bit, let me go through this slide first before I get into that. We always need to know where we stand. We see twice a day, every leader in our organization, our ED volume and the number of holds that are here, the number of patients that we have in beds, our number of planned discharges, our actual discharges. We know how many beds we'll need to support surgical operations. We also staff for the next 4, 8, and 12 hours based on anticipated discharges and admissions. We have developed, and I know everybody developed, models for what you think COVID is going to do, whether it's increased or decreased in the next 24 hours, and I'll share ours with you. Metrics, you can look at any time during the day. How many patients have discharge orders? Well, if you have a discharge order, I know you're going to go home in about 2.5 hours. If patients have left already, I know that bed is going to be available in about an hour because that's how long it takes to clean that bed. I know what beds are being cleaned right now, so if I'm the nursing supervisor who's doing bed placement, I can place people in beds that are actively being cleaned because I know, and I don't have to guess, I know it takes 50 minutes once you assign a bed to a patient in the ER for the ER crew to get that patient upstairs. And they can go in that bed as soon as it's done being cleaned. I also know what patients still need tests, and if those tests are available at the hours that you have in advance, because you may have a procedure or test that's the only thing that's keeping the patient in the hospital. So we can escalate that. We call it escalation huddle. We huddle every day at 11 o'clock, 7 days a week, to look at barriers to discharge. On 12/23, our ED volume was 137 with 9 holds. Pre-COVID, our ED volume ran around 200 a day. I knew at 7 o'clock in the morning I had 101 discharges potentially on that day. I knew the day before was a light discharge day at 64. I knew that we had 23 surgeries. And I knew that we had the potential to go to a census of 124 COVID patients. on this day. This is also the day, and I saw in the questions, and I'm going to answer it because this is the point where I saw it. We quickly put in place the ability to accept transfers from other Syracuse hospitals to cross-balance patients. And on this day, the 23rd of December, we were able to take 13 patients from the other large university health system in our community so that they could continue to be open for trauma and burn care. Here is COVID demand, and this is, we would do a slide deck that we send out to our entire organization. Every day our incident management team met. We met on this day, and this is the slide from that day, 12/23. This is where we anticipated COVID to be going forward. The potential high, the potential low is on there, as well as the ICU potential high and potential low. COVID staffing, and I think this is important. This is something that we worked on actually over the summer when we had a pause. We anticipated that we would not have sufficient staff to maintain our acute care capacity if the number of COVID patients increased significantly. So in October, our leaders had the foresight to ask all of the non-acute care areas to give 20% of their staff to the acute care operation. And it gave us an opportunity to take nurses and techs and analysts and all sorts of people and train them in the things that we needed them to do during the pandemic, to give them refreshers and basic med-surg care, we would have analysts help people don and doff before they went onto our negative pressure COVID areas. But we started that in October, so when we were at the peak in December, we were able to expand the number of acute care med-surg beds by almost 30 beds. So that gave us capacity as we look at our capacity ratio, and that really compares our staffing standard. We had changed our nursing staffing model during the summer to a 3 licensed people to 10 patient ratio that could flex up to 3 licensed nurses to 15 patient ratio. And on Monday, you'll see the ratio is high, and of course, this is the one that comes out on Monday. So by the end of the week, if you continue to admit at the same rate that you did before, the ratio goes down. But if you don't, it stays as high as it was on the first day. So the trick was always to not let the admissions outpace the discharges at any given time. So much work is going into the capacity ratio and COVID staffing. My good friend and colleague, Dr. Ryan Clapper, runs our capacity management center that does centralized staffing for the entire hospital. And I know that he could easily do an entirely separate webinar on that. And he absolutely can speak to that way better than I can. But I thought it was critical that you realized that discharging and being flexible enough to add capacity is how you maintain capacity. This is a length of stay comparison between St. Joseph's and one of the other hospitals, the other large hospital system in Syracuse. The Hospital Executive Council collects data from all the Syracuse hospitals so that everybody knows where they stand. They were able to provide me with this, and it is based on severity of illness, minor, moderate, a major, and extreme. And you'll see our mean length of stay is comparative here. But when you convert that into average daily census difference, you'll see that how much of a difference that makes. It is 85, 86 patients. For any hospital, and we're a 451 bed hospital, and the other hospitals are comparable to that. That is, for us, that's 3 nursing units. So length of stay has been critical. Managing length of stay has been critical to maintaining capacity. So as we look, what did all this get us? I guess is the question that everybody has. Hopefully they have. So let me share that with you. This is a hospital occupancy, and it's a 7-day rolling average. It is the inpatients that are med-surg and ICU and the observation patients. This is one hospital here in Syracuse through the period that we talked about, and struggling to maintain capacity. This is the other hospital system. I say it's a hospital system because it's actually 2 hospitals, and their struggle to maintain capacity. On the 22nd, like I said, we took 13 patients. The last week of December and the whole month of January, St. Joseph's was able to take 64 patients from the other 2 Syracuse hospitals in order for them to maintain their critical capacity. So when you add their capacity and St. Joe's capacity, you see that it goes below 95%. When you add the rural hospitals in, it goes below 85%. And to give you a picture of our 7-day rolling average during this period, that's where St. Joseph's was. We had 1 day above 85% that we were required to call the state. We were at 87%. I want to say that was on the 23rd, the day that I showed you. But we had a plan to clear that out. So, and we did clear that out. Finally, some of the summary, hopefully you got out of this, tell them what you're going to tell them what you told them. You know what I mean by continuous capacity during the pandemic. I talked about avoiding the tipping points. I also talked about knowing where you're at all times, and the metrics that tell you where you're at all times, so that you can act decisively in a crisis to meet really the healthcare needs of the community across the board. And with that, I think this is the point where we entertain questions.
Wonderful. Well, Brooke and Joe, thank you so much for such a great presentation. Like Joe mentioned, we'll now begin today's question and answer session. You can submit any questions you have for Brooke and Joe by typing them into the Q&A chat box you see on your webinar console. We've already had some great questions rolling in, so let's get started with the first question, which is, can you describe the process in selecting Care Logistics as a partner for creating the command center?
I can certainly describe that process. We chose Care Logistics because they had something to offer that no one else had. We did discovery with them not once but twice to convince ourselves that that this was the correct course of action and that there was a return on that investment, and we would get the results that they anticipated we got. And they were great about, through the implementation process, about setting mutually agreed upon goals for improvements in length of stay as you reach milestones in the project, and they met them and have been a great partner with us when we felt like we're not meeting the objectives that we had mutually set out on. They come on site and tell us why our cake doesn't look like the cover of the cookbook, which is how we always want the cake to look.
Wonderful. Thanks for elaborating on that process, Joe. I really appreciate it. The next question is, can you please talk a bit more about how you level loaded hospitals inside your network or area?
Well, we had met with Haney's and the hospital CEOs, and then we had actually another breakout meeting every day at 10 o'clock with the other two Syracuse hospitals to see what their needs were. We would go over the individual hospitals' stats, and we would offer capacity for the other hospitals. Sometimes they had the ability to transfer us patients. Sometimes they had the will to transfer us patients, but they couldn't operationalize it. But we had made it our policy to accept all the patients that they felt they needed to transfer at any given time, knowing that our whole community relied on the other hospitals as much as they relied on us to meet the healthcare needs in the region.
Fantastic. I think that's really helpful for our audience members to know. So thank you again, Joe. The next question is from an audience member who writes, earlier, you said you had issues with moving patients out of the ED. What results did you get in your ED from putting the command center hub in place?
Results that we got, really we set a target. The CMS definition of an ED boarder is someone who's had an admission order greater than 120 minutes. So we made that our target. As we did that, we continuously monitor patients and how long they've been waiting. Like I had said earlier, we admit 24 hours a day, discharge 12 hours a day. And what we had found prior to Care Logistics is that we ran out of capacity at about 1900 every evening, and anyone who was admitted after 1900 waited till noon the next day to get a bed. So what our hub has done is, expanded how many hours a day we're able to discharge people. It certainly expanded the number of people that we discharge every day so that we have enough capacity to last us really from 1900 till now it's more like 10 o'clock the next day. So what we see now, generally ED boarders are patients who, are admitted on the late evening shift. And some of them usually wait until 7, 8, 9 o'clock in the morning to have a bed. That now is our biggest logjam, but certainly our ER starts to get busy after 11 a.m., but the patients have already begun to move out. So we may have, 10 patients in the ER, at 3 o'clock, but they're not the same patients we had in the ER waiting for a bed at 8 or 9 o'clock. And we're continuously moving patients. We can also tell whether we need to add staff more beds because we have all the information in our hub.
Yeah, so just to add on to what Joe's saying a little bit, I think that in the hub you have visibility, or Joe has visibility as the manager of capacity to see whether or not, or how many discharges we're anticipating for the day. So when Joe comes in the morning, he knows, okay, St. Joseph's is looking for 101 discharges. We'll use our example from previous. So 101 discharges are going. Well, if you have much more than that in your ED waiting for beds, then that's a call to action. And we'll start talking about, whether we need to hold or whether there are other patients that are ready to go. So just having that visibility, I think, in the operational command center gives you the tools that you need to proactively manage the patients coming into your house from your ED and making sure that you have the beds that you need or the capacity that you need for all of those patients.
Our nursing administrative coordinator can see the nursing units, who has discharge orders, how long they've had a discharge order, if they specifically need a bed for a patient in the emergency room or hospital transfer. They'll literally call the unit up and say, I see Mr. Jones or Smith had his order to be discharged X amount of time ago. I see that he's going home without services. Is there any way he could go now? And really that moves us along. Right down to the patient level, the unit level, essentially 24 hours a day.
Wonderful. Appreciate you both weighing in on that question. Thank you. The next question is, what was the most impactful metric that was off when they started that had the greatest assistance once changed?
Can you ask me that question again, please?
Absolutely. The question is, what was the most impactful metric that was off when you started that had the greatest assistance once changed?
Length of stay was the most important thing. As I said in the presentation, for the same volume, we were able to reduce, we were able to not have to staff 57 beds. Length of stay is everything, and it's patient days out of your system. And as you get to the point where you turn over a quarter or sometimes a third of your volume, that's opportunities to move patients out of our emergency room or get patients in for elective surgeries or take admissions from other hospitals. Lowering the length of stay eliminates excess patient days and creates real capacity. We've looked at, well, if the doctors would just get their order in by 8, we could get the discharges out by 11. If we get the discharges out by 11, we can get the patients out of the ER by 2, and those, they don't get you there. They don't get you there. If you incentivize providers to get discharges by 11, if I don't discharge somebody at 6 o'clock at night, well, I'd get credit for it if I get them out at 8 o'clock in the morning, but then you've added a day to his length of stay. And once you get everybody on the same page working toward an established target, and I'll tell you that our targets for length of stay are generally the Medicare's geometric mean. So it's really, we want our patients to stay the average amount of time that they're staying across the country for the DRG. And once everybody works toward that, you lower the length of stay, you decrease the number of patient days you're using, and once you do that, you don't need as much staff, and you have tons of opportunities to move patients through your system.
And I think one of the other key successes, and I pulled the slide up, but I think one of the other metrics that really accelerated St. Joseph's to the level of capacity that they were able to reach is that not only did they decrease their length of stay by almost a day, but their CMI, or their case mix index, went up significantly. So the patients that they were seeing were sicker, and yet they were able to manage them better and more efficient. The goal is never to rush patients out before they're medically ready, because then you're just going to create a readmission, right? But the goal is to manage their stay so that you're eliminating that white space and they don't have a lot of time just sitting in beds not receiving care, because that doesn't benefit you and that doesn't benefit them. So I think that that's another really important thing, and care logistics looks a lot at observed over expected ratio, because that takes into account the CMI and what the targets, like Joe said, the geometric mean length of stay, and you can really see how you're performing, not just from a length of stay perspective, but also taking into account the acuity of your patients.
When you have patients who aren't going to meet the target set for that DRG, we simply ask providers to document why that is, and they have, by and large, do a good job of doing that. Like Brooke said, if you're not ready to leave the hospital, we don't want you to leave the hospital. But if you're ready, we want you to go. and your physician determines when you're ready or not. But as all of you know, if you've worked in healthcare before or work in healthcare now, the less time you spend in the hospital, the less opportunity you get to get a hospital-acquired condition. And the longer you stay is the phrase we like to say here. So as units work on their length of stay, they really embrace basic quality metrics of preventing hospital-acquired conditions. It turns into the longer you stay, turns into a vicious cycle if you let it turn into a vicious cycle, or you can have a huddle on the floor every day for all of your patients, a snap huddle, and where nurses are talking about the device and whether the device the patient still has is still indicated, and if it's not, the physician is there to discontinue that. And those are all progressing your patients and lowering your length of stay.
Absolutely. I think you both make great points. So appreciate you weighing in there. We have another question here from an audience member who's asking, how did you change the physician behavior for discharging earlier?
It took some buy-in. Probably the most scientific part of the whole process, and I've explained this to a number of the physicians certainly that we work with, is the setting the targets at the geometric mean or around the geometric mean. That is how their peers perform across the country. And really we ask that they try to perform at that same level. We are blessed to have a hospitalist service here at St. Joe's that manages the majority of our medical patients and probably 40% of the overall patient population. During COVID, when we only have medical patients, they're managing all of the medical patients along with our ICU team. They have learned to appreciate the targets and work toward the targets. But really providing providers with data, their team's data, it's very telling, and nobody wants to consistently not meet the mark. So they really have embraced it and changed where they needed to change and pushed back where they needed to push back. And by and large, they're always on board because what they've seen is our patients do better and our outcomes are better. And they got beyond you're just rushing people out, so they're going to be readmitted. Since we implemented care logistics, our readmission rates have actually gone down. Again, because the patients who get readmitted the most, if you look at that, are the patients who stay in your hospital the longest. So if you can get ahead of that, then you're ahead of readmissions.
Wonderful. It sounds like that data is really key, for that physician perspective. We have another related question here I'd love to get your take on, Joe, which is how did you encourage participation from nursing?
When we implemented the model, it was really a new patient progression model. It changed our old case management model to a new model that was 24 hours a day, that had a considerable more number of resources associated with it. So now we have clinical care managers who look at every patient on the unit and their patient progression, whereas before we had case managers who only looked at the most complicated patients. And what we were putting so much energy in the most complicated patients, the patients who stayed here 4 days but could have stayed here 3 days, we didn't pay attention to, or who could have stayed here 4 days but were here 6 days, we didn't pay attention to. And that was really a shift. And our CCMs, as we call them, are on every unit. They have a presence in the hospital 24 hours a day. They are the nurse leader that drives the rounding on every unit every day, and they are the people who elevate the barriers to leadership every day, and that really, gets nursing buy-in. I mean, you can't avoid them when they're standing outside your patient's room, wanting to go over your patients and what they're there for, what their barriers are, what they still need to get better faster is how we'd like to describe it.
Wonderful. Thanks for touching on that nurse buy-in piece. We have another question here more about the logistics of the process. Were the transfers inpatient, and what level of care were they?
When we got transfers in, we took ICU transfers, we took med-surg transfers. Initially, we were taking transfers from inpatient units at the other hospital. We progressed to the point where we would get patients from their emergency department before they were admitted, because we found that those patients were easiest to integrate into our system. If you're a patient in the hospital, you come through the ER, you do all the waiting that you have to do, and then you finally get into bed only to have somebody come and say, "Oh, do you want to go to the other hospital?" So they had a lot of patients who didn't want to leave because they were set. So we started to do was, when you were in the hospital and you were sick enough to be admitted, they would say, "We're going to admit you, but we want to admit you to the other hospital and send you to the other emergency department." And that really saved tons of work. If you've ever transferred a patient from your hospital, it's a lot of work. It is harder than admitting them to your hospital if you're the sending facility. So what we tried to do is find the path of least resistance in order for some percentage of the patients presenting at one hospital ended up at our hospital. And it was especially onerous because the other big hospital system, they only take people in, they don't transfer people out. Rural hospitals routinely transfer people, they're good at it. But if you're a place that only takes patients in, that's a change for all your people that they have to accept and embrace and make happen. On the first day we took 13 patients, we'd offered to take 20 patients. And 13 is what could get organized on the other end.
Great. Thank you for clarifying that for our audience members. Looks like we have time for about one more question, which is from an audience member who writes, "You mentioned the focus on diagnostic services. Was this through your centralized scheduling?"
We have order organizers who get all of the diagnostic orders on the inpatient side and in the emergency room, and they decide on the priority of those patients based on where those patients are in their stay. So patients who, obviously stat trumps everything, but the routine orders are done in the order based on when we think that patient is supposed to go home, when their anticipated date of discharge is. So if you're anticipated to go home today, you'll get your exam before someone who maybe isn't anticipated for 2 more days. So yes, all that is. Go ahead.
Yeah, please go ahead.
No, I said, so yes, that was it used to be all the diagnostic entities scheduled their own exams, and it was not a challenge, but a continuously thing that we had to work on in order for them to cede that level of control to our centralized hub.
And the order organizers also, we talked a little bit about eliminating that white space, and Joe alluded to the fact that prior to this role being in the hub, each of the different diagnostic areas were managing their own schedules. With the help of the order organizer, you're able to manage complex patients who have a number of exams. Maybe they have an X-ray and a CT and an MRI, and we need that X-ray, CT, and MRI to understand how to care for this patient. Those can be, scheduled so that you're not having them go back up to their room and then coming back down to the next service area. So not only does it eliminate white space for the patients, but overall, it's just a better patient experience for those complex patients who need multiple tests.
Fantastic. Well, that is all the time that we have left for today. So, Brooke and Joe, I just want to thank you again so much. This has been such an informative presentation. And I'd also like to thank Care Logistics for sponsoring today's webinar. For our audience members, if you'd like to learn more about the content presented today, please check out the resources section on your webinar console and be sure to fill out the post-webinar survey. Thank you all so much for joining us, and we hope you have a wonderful afternoon.
Thank you, everyone.
Thank you, guys.